At this point, let me introduce Dr. Michael Weber. I am honored to have this conversation with him now, and I would appreciate it if you would introduce yourself rather than have me do the honors.
Well, thank you. I've spent most of my career in the field of what you might call preventive cardiology, which in essence means dealing with high blood pressure, lipid disorders, and diabetes, and other factors as well. But that basically summarizes it. And I've been especially closely involved with high blood pressure. I was part of developing many of the drugs that are now commonplace for the treatment of hypertension. In fact, I go back far enough to recall being part of the controversies about whether beta blockers could be used for treating hypertension. And then I was very much part of being involved with ACE inhibitors. In fact, I was present when the first patient received an oral ACE inhibitor. I was very much part of helping to develop the angiotensin receptor blockers and so forth. And even now, I've been involved in the brand new endothelin antagonist and also involved now with some of these very sophisticated messenger RNA, microRNA therapies, also targeted at hypertension and also, for that matter, lipid disorders. Uh, Going back, I'm a professor of medicine, initially at the University of California, Irvine, for several years, and more recently, professor of medicine at the Downstate Medical School in Brooklyn, New York, former president of the American Society of Hypertension, very much involved in international hypertension as well. I've been on the board of directors of the International Society of Hypertension, and currently I'm on the board of directors of the World Hypertension League. Very much interested now in how all the research we've done over these past many years can be integrated into clinical practice, so-called implementation, which is very difficult. We all know how to treat hypertension. How do we get physicians to prescribe correctly? How do we get patients to take their medicines? Those are very big issues. I've been involved with the regulatory parts of hypertension. For many years, I was on the FDA's Cardiovascular and Renal Drugs Advisory Board. Still am technically an advisor to that. And for 10 years, I was the chairman of the formulary committee for the Anthem WellPoint pharmacy benefits organization. So I've seen all sides of this, and uh, now I feel as though the work ahead of us is perhaps even more difficult than it was already, getting all of this knowledge, all this experience into practice. We have terrific tools, terrific knowledge, terrific guidelines. What we don't have is adherence to treatment. Fewer than half the patients with hypertension in the United States have their blood pressures under control. And that's just using the 140 over 90 definition of hypertension. If we use the newer, now worldwide recognition that 130 over 80 represents hypertension, guess what? Only 26% of American hypertensives have their blood pressure under control. Pretty dismal, isn't it? And we've got a lot of work ahead of us. So, Russ, that's a rather long-winded introduction to where I've been along the way and where I think we've come to.
Well, let's pick up on that. When you talk to people with hypertension and you explain that lowering blood pressure adds life to years and years to life, what do they really resist about drug treatment? I have a point of view, but I'm interested in your point of view because I agree. The challenge today is implementation.
Yes, yes. It's. Let me put it this way. most people do understand that high blood pressure is a risk factor for premature death.
Long-term risk factor. And yeah, the point that I'm trying to get us to is I think most people make short-term decisions. There are only so many things they can do during a day to promote their well-being, their epigenetics. But we've had quite good success in diabetic populations, both type 1 and type 2, by paying attention to the client, meeting every 2 weeks for a Q&A session that informs, motivates, and inspires. We got excellent uptake, adaptation. And then we use predictive biomarkers like hemoglobin A1C, Paul Gallup's contribution from the late 1960s, I feel today is more revealing to me what your percentage hemoglobin A1C is more revealing to me than your momentary blood sugar or blood sugar insulin ratio. It's an easily available, inexpensive test that personalizes the need. On marketing platforms, they want to get your hemoglobin A1C down to 7. I want to get it to 5. And mine has been 5 since I lost weight. So at one point, I weighed 65 pounds more than I do now. And my hemoglobin A1C was appropriately elevated. I found a way to lose the weight and keep it off. And now I want to personalize the plan. I want to make the long-term benefits so immediately helpful that people will make this part of their daily regimen, part of their lifestyle, their epigenetics. Do you agree that health coaches can play a role in informing, inspiring, and motivating people to follow the recommendations of their physicians, given how little time most physicians have with each patient today?
Yes, that is a big problem, how little time physicians have with the patients, a serious problem. And everything has become very superficial, quick, on to the next thing. Uh, you have an advantage in a sense when you talk about hemoglobin A1C because it's an integrative observation that takes into account several months of what's been going on as far as glucose management is concerned. We don't have that with hypertension. Yes, we have a sort of equivalent, which is to do an echocardiogram and make an estimate of left ventricular muscle mass. And that's not a bad thing to do, but it's an expensive procedure. There has to be an indication for it. It means sending the patient somewhere else to get it done. So it's not as simple as simply ordering an A1C. And I wish we had something that would bring all of this more closely to patients' minds. Uh, More and more people, the good news is more and more people are checking their own blood pressures at home.
Mm-hmm.
And that is useful. Though when you talk to them and see what they've written down on their list of blood pressures when they come to see the doctor, I have a very strong suspicion what I'm looking at are the blood pressures that they liked and wrote down, not necessarily the blood pressures they actually had on all occasions. Uh, the other problem we have, Russ, I mean, you said, okay, we got something very clever going on with coaching in diabetes. You think about it. Most of our patients are not young. Some are, of course, and they're very, very important, actually. The better job we do with them, that's going to magnify out to better and better benefits as they age. But most of our patients are in their late 50s, their 60s, their 70s, their 80s, 90s. And I know when I see patients, it's yes, your blood pressure is this and that. but they're more interested right now in what's happening with their diabetes, or they're more interested right now because they've just heard something about cholesterol. Uh, they're particularly interested because they have an upset stomach, and can I prescribe a PPO for them? They're more concerned that they're not sleeping well. Can I prescribe something for that? They're more concerned that their left knee is getting more and more painful. Can I prescribe something a little bit stronger than ibuprofen? Uh, they're telling me they've been kind of in the dumps lately, feeling depressed. Could I perhaps prescribe an antidepressant? And I'm not their primary care physician. I'm seeing them for hard to control blood pressure, but it's one item on a long agenda of items. In fact, some of them actually literally come in with a long agenda of items they want to talk about. So it gets to be very difficult to do an adequate job on high blood pressure. I am hoping that improved home blood pressure devices, which actually are intelligent, or now I guess we would say have AI capability, will start to talk back to patients and say, have you taken your medications? What sort of diet are you on? When was the last time you saw your doctor, so that there could be perhaps a further evaluation of your blood pressure? I hope that sort of technology will help us to do a better job. Uh, and there certainly is the equipment and knowledge out there to allow that to happen. But getting it done, bear in mind, the economics of healthcare now is that almost a majority of primary care doctors are working for corporate entities whose primary goal is their bottom line, not the well-being of their patients. And you only have to read the newspapers to see all the investigations going on of the big healthcare providers to know that they are not in it for the love of mankind. And that's become a problem for those of us who really worry about the patient.
Well, in terms of measuring blood pressure, I use an Omron device at home. Upper arm, a little bit better maybe than wrist, but wrist is easier to perform. And you know Harry Gavris, when Harry takes Carl's blood pressure, he waits and takes it again and waits and takes it again, and he tells Carl a joke in the middle, and then Carl's blood pressure relaxes. I have white coat hypertension. I do. When I go to a doctor and the first thing I see is a machine, I want I want them to know that I know what my blood pressure is, because I think that's a very important measure. And my blood pressure tends to be 100 over 70. I get restorative sleep. I didn't used to, but I do value now restorative sleep. And I take supplements to assist my physiology. I want physiology before pharmacology. That's a little bit provocative, but I really believe that if we engage fully with lifestyle, taking a 20-minute walk outside in a forest, a glade under a green canopy, or using a green light, can dramatically improve your brain function, your digestive function, your joy of living. I think people pull in more and then get more and more sad, disconnected, when we should be reconnecting continuously, renewing our bodies continuously. I'm amazed at what nature, nurture, and wholeness can really do when a person is motivated to follow through. And I'm so appreciative of what you're saying, because there are structural issues today that prevent well-intended physicians from taking the time to build a relationship, to have rapport. The social determinants of health turn out to be very important. and are more and more overlooked by just what you said, a corporate system that says 12 minutes per patient. That's not the rapport I want to have. And fortunately, I'm able to walk my talk. And I feel so much better for doing it. So there are, I think, ways of reinforcing the habit change, because this is, for most people, a change of habits. Stop ultra-processed foods, stop most grains, have more whole fruits and vegetables and root vegetables, and coenzyme Q10 as a supplement can sometimes help with blood pressure and with cardiac function. I think you've really nailed the structural issues. And that's why I keep coming back to health coaches. I think just like acupuncturists have become a profession, nutritionalists have become a coaching profession. I think people deserve to have their own personal health coach, and then build a relationship with that person and say, well, my doctor wants me to do da, 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 but I didn't really understand what he was saying because I didn't have enough time to unpack what was being said. And the health coach might be able to fill that void.
Yes, yes, I think that would be terrific if there were health coaches available, accessible to people, and affordable. I mean, health coaches, that is being these are professional people. They have to be compensated.
Oh,
Uh,
yes.
and
But
how is this going to
if you
be
look at the
done and organized?
if you look at the self-insured companies, SC Johnson, Safeway, and similar, they pay for the health coach because they save so much on the other side in avoiding chronic metabolic acidosis, chronic high blood sugar, diabetes, weight, attitude, restorative sleep. When you put that all together, you can add life to years and years to life. I think the leaders of today's medicine, Don Berwick, Elliot Fisher, Harry Gavris, are in agreement with you, with us, but we see the structural barriers. And if you get trapped in 10-minute medicine or get trapped in downstream conventional care rather than upstream prevention, I think there's enormous opportunity for upstream prevention, but young doctors today have so much pharmacology and related things to understand that lifestyle very often gets the short shrift. So that's why I come back to wanting a liaison, wanting someone who can motivate, inform, inspire, and personalize the program, and then encourage the person, give me a month or 2 or 3, and I'll change your life. That's possible.
Well, I agree completely. That is an ideal approach. But what do we see in the newspapers? Excited articles about yet another chronic important condition can be treated with a GLP-1 agent. Yes, it's a pretty expensive proposition, but my Lord, it'll solve everything for you. You don't have to think anymore. Just place one little injection once a week, doesn't even hurt. It's all set up for you. And soon it'll be an oral treatment anyway. Uh, and by golly, it's going to solve your blood pressure, your lipid problem, your diabetes, your weight. Life is good. Life is easy. Just bring your checkbook. But it's obviously not as simple as that. And we know that for many medications, as long as they work, they work. but if you stop taking them, they stop working. And what stuns me is just looking at pharmacy records. I haven't done it personally, but I've read the articles of people who have, and it's called not. It's called persistence. That is the technical term. What is the likelihood that someone is going to renew their prescription when it runs out? In other words, they're going to have to call the doctor or arrange to have the prescription renewed for the next 6, 12 months, whatever it might be. And it's extraordinary how low that percentage is. And it depends on the type of drug, of course, and the focus of the patient. For instance, one of the things that those of us in the hypertension area have always been fascinated by is the differences among drug types. For instance, with an angiotensin receptor blocker, there's a pretty good persistence. About somewhere between 60, 70% of patients are still taking it a year after it's been prescribed. Not so good with the beta blockers, and even worse with diuretics. Only about 20 to 30% of people prescribed a diuretic as a distinct drug will be renewing it a year later. People don't understand diuretics. They think they're going to make them pee more and make life very inconvenient and difficult. I've had patients tell me, he'll say, "Doctor," as though you don't understand. "Doctor, I got to tell you something. When you take a diuretic in the morning, you can't go anywhere. It's no good having a 10 o'clock appointment because you can't drive far enough because you got to go and look for a place to find a toilet and all that sort of stuff." Of course, it's not true, and people don't understand diuretics, but that's the sort of thing you deal with. Much better to give a drug like an ARB, which has got zero side effects. In fact, it's truly like taking candid. There's no perception of a medication at work, and that's part of the success. But uh, it gets very frustrating, and we're in competition. How do you handle a person of 75, 78, good, active, intelligent person, still doing a little bit of part-time work, helping out at charities, doing good deeds, being a very good grandparent, all those sorts of wonderful things going on. Um, but they're on 11 different medications. Right? And they come for what, as you put it, the 12-minute visit. And that's only if it's a morning visit. By the later in the day, when the doctor's way behind schedule, it's more like an 8-minute visit because he's being yelled at. Hurry up, hurry up. We got too many people in the waiting room. So the problem of multiple pharmaceuticals, which one should you renew, what is doing what? And you bring up a further complication. What about things like these Q enzymes, all these very interesting, let's call them supplements? How do they fit in, and how do doctors add those or recommend those to the regimen that's already a whole page list of medications? We've got to figure that one out.
Well, what you said is absolutely true and documented, but half of those medications are for the side effects of the other half. And very often medications are continued beyond need by protocol. It's just easier to continue whatever we've been doing.
Uh-huh.
What we try to do is anchor it back to something they value in their life. And then whether it's measuring resting heart rate during restorative sleep, or blood pressure, or hemoglobin A1C, or measures of inflammation, then I think very quickly the consumer gets confused because there's a powerful messaging that says supplements haven't been well enough studied. We don't know about the interaction between medicines and supplements. My boss at NIH, Don Young, did the dietary effects on medications and then the medication effects on dietary needs. A huge arbeit, a big piece of work, too complicated for most doctors to use today. So we hopefully can soon make accessible with technology and the like understandings of what you need to thrive, what you need to more than just survive today. And that means changing some habits. Ultra-processed foods do not have any place in my diet, but high-fiber whole foods do. Anything that comes in plastic, I avoid because microplastics are becoming pervasive and probably related to kidney, heart, brain dysfunctions. I'm in your target age group, but by my predictive biomarkers, I'm functioning at about the age of 40 when I'm twice that age chronologically. And I think most people can feel and function better if they will understand prevention rather than just treatment. Sure, we need to treat symptoms, but very often the physician doesn't see the interconnections of lifestyle, of habits of daily living, and therefore they miss the opportunity to reduce the number of medicines, improve the quality of life for the person, and be able to document that some way, cost efficiently, preferably. This affects millions and millions of people. And it burdens every aspect of our systems. Our analysis is that we could save 1 million lives a year if we just control diabetes and hypertension, if we gave good nutrition and hydration to people, if we took away some of the stresses of daily living that people are burdened by. You can save 1 million lives and you can take $1 trillion out of the $5 trillion we spend this year on sick care and healthcare. $1 trillion at least could be diverted to paying for speeding the transition from the current symptom reactive care to a truly preventive lifestyle approach. When I do talk to colleagues, they basically say what you have just so succinctly said, and then they shrug as if that is just the way it has to be. I think the system is part of the problem. I don't think we educate physicians enough on lifestyle, attitude, environment, nutrition, hydration, etc. And then the physician gets asked by the client, what about CoQ10? What about something that I hear might be helpful? I get about 40 milligrams a day of beta blocker foods. I would prefer a diet that's rich in beta blockers than a prescriptive beta blocker. If I need to, I will combine, but I start with the nature part first, and very often that is sufficient. As long as you can make it personal. In general, we know the problem. In specific, too often I think people are fatalistic. They assume that with age comes suffering, disability. I profoundly disagree. I think your functional age can be younger or older than your chronology. And you can, with a few simple predictive biomarker tests and self-assessments, you can engage with the person so that they can see in some detail how much quality of life they could gain back if they would invest a little bit of time in themselves. Well, in our book, we say 72 minutes. 72 minutes turned out to be 5% of your time. If you'll invest 5% of your time in living better and more healthfully, you can document quality of sleep, blood pressure, blood sugar, stress hormones. All of this gets better if you're willing to engage with it. So I think we have a big opportunity to improve the health of this country one person at a time.
Yeah, great. That's a wonderful summary of what ought to be, and I couldn't agree more. Um, in a way, we have been hurt by the rigor with which we train our students. So if we had a senior medical student with us now, uh, and you asked him or her what you think of what I've just said, they would say, "Could you show me the randomized, double-blind clinical trial that showed that compared with placebo or compared with some standard of care, this particular treatment was superior?" And of course, so much of what has been shown to be of interest and benefit along the lines you're talking about, uh, unfortunately, has not been part of the kind of clinical trial that would make the FDA said, yes, this, what you see in this bottle is indicated for the treatment of this or that. And that's the way we train young people to think, unfortunately. Did you have a significant p-value when you did your clinical trial? And let's go from there. The idea that there are things that perhaps don't have to be validated by that kind of scientific rigor, that's more difficult to explain.
Indeed, that model, the pharmaceutical model for the drug side of FDA, is well described and mostly well executed. But the food side, the last strong director of the food side of FDA was Sanford Miller. I don't know if you remember him, but that was many years ago. And yes, there's something like this that goes on, which means we don't have enough information in large-scale, double-blind, placebo-controlled trials, blah, 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 blah. Therefore, we're going to throw the baby out with the bathwater. That's oversimplification, but too often I do feel that if we were looking forward in the trials we're now doing or going to be doing, and included these social determinants of health, which can be measured. People will generally tell you what you want to hear, but you can actually monitor to know what's truly going on for them and with them. And I think when people feel really cared for and cared about, they're more engaged. If everyone could have a doctor like you that would have enough time and resources, because I do think that nurse practitioners and physician's assistants and health coaches form a team around which the physician can be the king or the queen, but the implementation, the actualization comes from the team. You do have to spend money up front to yield the rewards downstream. I think it's ready for these myths, prevailing myths, to be exploded and people properly informed in light of what we do know today that they can do for very little cost, but commitment to act and to choose. I tend to walk 20 minutes morning and evening. If I get 6,000 to 10,000 steps in a day, I feel better. If I only get 2,000 steps a day and I sit in front of my screen and my computer, I tend to not feel so well. So I'm so grateful for your insights and wisdom. May we all find the ways to be well and happy on what we need in habits of daily living and medications. And may there be a renaissance of the kind of physician that you are, and that I think there is enough evidence today to say if we were back to the future, restore private care, have a relationship, not just a 10-minute slot. Things could, should, would get better. So thank you very much for today. You succinctly pointed out the opportunity and the need. Too often people sacrifice too much of their life and they look back and they say, well, if I had only been better hydrated and ate whole foods and avoided ultra-processed things, and et cetera, et cetera. I'm like you, I'm very much committed to the notion that prevention can afford great success for minimal upfront cost, and that we can be well and happy, mostly. There are always stresses in life, but I now am convinced that I can lower your cortisol, raise your DHEA, I can lower your adrenaline, I can raise your melatonin, serotonin, tryptophan as the source. Yet most of our colleagues don't know that. They haven't heard the news.
No.
I fortunately was skeptical enough to go and immerse myself in what I now believe in passionately, because I've seen the results personally. So thank you for today. Thank you for being who you are to the world as well as to your family.
Well, thank you, Russ, and thank you for a delightful conversation and for bringing to mind some very, very important thoughts that hopefully we will learn to apply in the future. Thank you so much.
Be well.